presentation, Rick Teal, Dr. Araki. The talk will be about prone-lateral and applications from degen to complex. I think the first thing to clear, I think the word prone-lateral can be confusing because lateral can be done in a trans-psoas and a pre-psoas fashion, and a prone-lateral should properly be termed prone-trans-psoas, which would be the focus of this talk. I'll talk about some tips and pearls and show some cases. So the fundamental difference between the MIS and open is the workhorse of the MIS with the anterior column, and you can use the posterior column selectively when you need to shorten the column, do more correction or direct decompression. With open, you focus on the posterior column only, and that's for your workhorse. And what prone trans-psoas afford the surgeon is that you can have access to the anterior column and the posterior column simultaneously. The specific patient selection for minimally invasive approach for more complex cases could be pretty involved. We put this review together to put together all the algorithms that ISSG group in the MIS arm have put together with MISF2, use of ACR, which in the new MISF algorithm is replaced by the concept of fractional curve. For surgical planning, where you put the interbody at L5S1, you basically want to do ALIF. At 4-5, you want to do lateral. And if vascular anatomy or psoas anatomy is not favorable, do a TLIF. And Dr. Anand will probably talk about it in his talk about the surgical checklist of complexity of deformity that we've taken on. And when you first adopt prone trans-psoas, the first thing to realize is, as I said, this is not a lateral trans-psoas surgery. It's not the same operation. And the gravity could be a double-edged sword. It helps you with the positioning, but the moment you start your approach and start docking, the gravity works against you, and there are tips and tricks how to avoid that, and when and why I do prone surgery in some specific cases that I discuss here. So this is a patient in his 40s, mostly back pain, has a flat L4 to S1. It is 30 degrees. You want that to be about 45 degrees, maybe 50, with a PILL mismatch of 26 without a fractional curve. L4-5 psoas is a little bit anteriorly transposed. You see the degenerative disc disease from L3 to S1. Truncal obesity, this is something that you probably want to avoid when you start first doing prone trans-psoas because the depth of the surgical field is much larger than you would anticipate. So I did L4 to S1 ALIF with prone trans-psoas at 3-4 with percutaneous pedicle screw. So one of the tips to avoid that depth of surgical field and to reproduce that breaking of the bed that you have in the lateral trans-psoas is to break the bed using the patient positioners, as you can see here. Another tip to avoid going too anterior in a prone trans-psoas is to use navigation, and using navigation for soft tissue purposes. So the way I like to use it is I do my spin, put my screws in, and then I use the navigation to figure out where I would dock within the disc space at about a 30-yard line. And then you can get perfect positioning on the disc space. I like the two-blade retractor. That gives me an orientation. The blades are pointing the direction of the disc space, and with the soft tissue navigation, you get it perfectly on the 30-yard line when you open it, and either anteriorly if you need to, or posteriorly to get that width that you can put as big of a 22-millimeter cage. So this is a video of the same patient doing the prone trans-psoas at 3-4. You can skip that. So this is a 2-year post-op and improvement of the lumbar lordosis of 58, mostly at 4-1 with 41 degrees. Next case, 46-year-old, mostly back pain. There's not really a sagittal plane deformity here. It's just a mild degenerative scoliosis. These are the images from the previous experience of dealing with truncal obesity. I did not want to go prone at 4-5, so I just opted to do 4-1 ALIF again and 3-4 prone trans-psoas. Another option here is that you can adjust the bed height. So you want to start seated. Once you put your shim in, then you can rotate the bed away from you and match the C-arm so you can work in a standing position to avoid that kind of fatigue and awkward position that you would have seated, especially when you use loops that are designed to look down and you're constantly trying to look up, which is not ergonomic. Another thing in a PTP is peritoneal creep. You can see here the peritoneal content is creeping in between the two blades. And I think this is trademark now, Dr. Ribe. This is a quandam that we wrap the retractor to avoid this peritoneal creep. And then when you want to put the rod in, you want to unbreak the bed. So that's the same patient, 4-1 ALIF, 3-4 lateral in a prone position. I'm not sure if I have time. We'll just go with one more case. Okay, this is a mild degenerative scoliosis. These are the parameters without a fractional curve. I like to use the EOS image of the patient. They love taking a picture of this before and after surgery to see what kind of correction they get. This is a God's gift to a lateral surgeon. There is no disc disease or facet arthropathy at 5'1". So this is all the vacuum phenomenon, degenerative scoliosis. These are the cages going at 4'5", 3'4", 2'3", working from bottom up, and then putting a perc screws and getting a correction of that mild degenerative scoliosis. And that's only a 6-week post-op. Last case in the last 30 seconds. So this is a grade 1 spondy at 4'5", 4'1", hypolordosis. The parameters, again, the EOS image. Patients love this. These are the MRI. You can see the degenerative disc disease starting from L3-4 really down to 3-1. You can see the mild degenerative scoliosis here. The ALIF at 5'1". And 4'5" is very important. I don't let the residents do 4'5", to be honest with you, because I'm just not comfortable to linger in the psoas too long. But the 3'4", I let the residents take over. Going over time here. I'm already getting nervous because the retractor is coming out. But you can see the nice correction by putting the placement of the interbody devices and the correction. I think I'll just stop here. I went over time. Thank you so much. Thanks.